Hello, my topic is necrotizing soft tissue infection. Definition: are infrequent but highly lethal infections. They can be defined as infection of any of the layers within the soft tissue compartment: dermis, subcutaneous tissue, superficial facial defection, or muscle that are associated with necrotizing chains.
Necrotizing soft tissue infections, or NSTIs, are characterized clinically by fulminant tissue destruction and systemic signs of toxicity. NSTIs can include involvement of the epidermis, dermis, subcutaneous tissue, fascia, and muscle. The pathophysiology of these infections is the same and is the result of either bacterial penetration of skin and mucosal defenses after tissue injury or with origination in the deep tissues without a clear portal or source. Bacteria gain entry into areas of relatively poor blood flow and hypoxia, which is followed by bacterial overgrowth, release of exotoxins causing local tissue damage, and widespread necrosis. Type 1 NSTIs, or polymicrobial infections, are most common and typically seen in patients with comorbid conditions. Gram-negative enteric bacteria are seen in combination with gram-positive organisms and anaerobes. Type 2 is monomicrobial, usually due to group A strep, has a more virulent course, and occurs in younger, healthier patients. Certain comorbidities and risk factors may predispose patients to this disease, including advanced age, obesity, diabetes, alcoholism, vasculopathy, IV drug use, immunosuppression, end-stage renal disease, perirectal abscess, perforated viscus, and recent surgery. Exam findings can include erythema, swelling, induration, and early tenderness. Late findings can include skin discoloration and a violaceous erythema, bulla and crepitus, pain out of proportion to examination, or anesthesia of the affected area. Most patients quickly develop signs of systemic toxicity, including high fever, nausea, vomiting, malaise, altered mental status, tachycardia with associated hypotension, and oliguric renal failure. Lab findings may include a leukocytosis with left shift, acidosis, hyponatremia, elevated lactate, and elevated inflammatory markers. Imaging is not necessary when there is a high level of suspicion and may delay early treatment. When the diagnosis is unclear in a stable patient, CT findings consistent with NSTI can include gas across tissue planes, fluid collections, asymmetric fascial or muscle thickening, and diffuse areas of soft tissue inflammation. The mainstay of treatment is aggressive early surgical debridement. Debridement should extend back to viable soft tissue and muscle that exhibits brisk bleeding. Return to the operating room within 24 hours or earlier for a second look should be strongly considered.
Application in nursing. Taking viral signs. Good bunker. Take a tissue sample biopsy. Log the result of blood tests to see if there are signs of infection and muscle damage. Rick's imaging test. Computed tomography, magnetic resonance imaging, ultrasound of the damaged area. Pros and cons. Treatment. Early treatment of necrotizing fasciitis is critical. The sooner you start treatment, the more likely you are to recover from the infection and avoid serious complications, such as limb amputation of leg. Treatment can be performed in an intensive care unit (UCI) in the hospital and includes intravenous antibiotics, surgery, skin graft, hyperbaric oxygen therapy. Risk factor: having a weak or compromised immune system, chronic medical conditions such as cancer, diabetes, liver or kidney disease, cut and squeak on the skin, surgical wound on the skin, recent history of viral infection that cause a rash. For example, chickenpox. Use of steroid medication which can cause a decrease in the body's resistance to infection. Signs and symptoms: erythema, vesicles, intense pain, fever, general discomfort, myalgia.
Necrotizing fasciitis. A young patient sustained a small laceration to the leg and was taken to the emergency room 3 days after the injury. The patient had pain, redness, erythema, fever, and low blood pressure. A culture was obtained from the wound to determine the presence and the type of bacteria in the wound. Gram stain showed gram-positive cocci in chains. It was a group A streptococci. Necrotizing fasciitis is also called a flesh-eating bacteria or disease. It is a limb and life-threatening soft tissue infection. Early diagnosis and adequate treatment is important to save the life or the limb of the patient. It usually occurs after a minor trauma. It may be associated with chronic diseases or illnesses, usually found in alcoholics, diabetics, after insect bites, or post-surgery. Mortality rate is about 33%. This is published data. It is underdiagnosed because it resembles low-grade cellulitis. Surgical debridement should be urgent. Delay in surgery more than 24 hours is associated with increased mortality. Diagnosis: pain and tenderness beyond the apparent margin of infection is diagnostic and found in about 98% of cases. Group A strep is common, but other polymicrobial infection will start and involve the fascia, and the toxins will spread. Other findings in the diagnosis, and these are published data, includes erythema 100%, bully formation less than 50%, crepitus about 14%, skin necrosis about 14%, tachycardia about 75%, fever 50%, low blood pressure, hypotension, or we call it septic shock, is not very common. It's about 18%. Treatment. Early diagnosis is important. Aggressive and extensive debridement of the affected area. Always obtain a biopsy from the periphery and not from the necrotic center. Debridement should be repeated on almost daily basis. Give antibiotics according to the culture and sensitivity. You can use hyperbaric oxygen. Usually there is good result for clostridial infections. There is a high incidence of extremity amputation if the fascia is penetrated by the infection. Case examples: patient number 1. Here is a necrotizing fasciitis involving the volar aspect of the arm and forearm. You can see the hand is also involved, so as the dorsal aspect of the elbow. You can see the function after debridement and skin grafts. This is patient number 2. You can see minimal cellulitis. So these cases really occult, and you can see the significant pus pouring out of the wound. This is a patient number 3. You can see the extensive debridement of the arm and the forearm volarly. Major debridement is also done on the dorsal aspect of the arm. Here you can see the wound is covered with a skin graft. Patient number 4, the disease involved the forearm and the arm. Here you can see the smoking gun, which is the bully, the black dots on the skin. That's almost a very important key in the diagnosis of necrotizing fasciitis. All my videos and
AG applied in Ecuador. Necrotizing fasciitis is a rapid infection of the skin and soft tissue that is usually associated with significant systemic toxicity. Its incidence just increased in recent years, currently affecting 1 of every 100,000 inherent in our environment. It is the most serious form of soft tissue necrosis and development in one sort of patient of shock and multi-organ failure. Conclusion: necrotizing fasciitis is a rare but life-threatening disease that can affect any part of the body. There must be a high degree of suspicion due to the pose of the specific autonomous manifestation. The history and the clinical picture are the key elements for the diagnosis. Immediate aggressive surgery is mandatory despite all the measures. Mortality remains very high.